Welcome to the deep dive. Today we're jumping straight into microscopic polyangiitis, or MPA. If you need a fast, high-yield overview, maybe for exams or just to get up to speed, this is for you.
Absolutely. We're talking about a rare autoimmune disorder, basically inflammation in the small blood vessels.
Right, and that hits organs like the kidneys, the lungs, pretty important ones.
Exactly. And it's one of the ANCA-associated vasculitides.
Yes, the ANCAs. Anti-neutrophil cytoplasmic antibodies.
Precisely. These antibodies, well, they mistakenly target parts of our own white blood cells.
And the big question is why, isn't it? Why does the immune system do that?
That's still the puzzle we're trying to solve. The exact trigger remains elusive.
Okay, let's break it down further then. Definition time.
So recapping, MPA is that rare autoimmune condition, inflammation of small blood vessels, vasculitis.
Key targets, kidneys and lungs. And don't forget the ANCA link.
Right, and digging into the why a bit more.
The etiology.
Yeah. We don't know the exact cause, but we know it's autoimmune. The body's fighting its own vessels.
Like friendly fire in the circulatory system.
Good analogy. And we think it's probably a mix of things, genetics, maybe environmental factors.
Any specific triggers suspected?
Well, potentially certain medications or infections, maybe even other underlying diseases could kickstart it in susceptible people.
Okay. So speaking of susceptibility, who's actually more at risk here?
It's interesting. There aren't really strong, specific risk factors like you might see with other conditions.
No clear red flags there.
Not definitive ones, but things like a family history of vasculitis or maybe other autoimmune diseases might play a role.
Environmental toxins, genetic quirks.
Possibly. Those could slightly increase the risk. And age is a factor, too.
Right, you see it more often in older adults.
Yeah, it can happen at any age, truly, but it's definitely more common in people over 40.
Let's zoom in then. The pathophysiology. What's happening on that small scale?
So the core issue is inflammation, right?
Yeah.
And damage to the walls of those tiny blood vessels.
Caused by...
White blood cells getting involved, and those ANCAs we keep mentioning, they directly target and injure the vessel lining.
Okay, and the consequence of that damage?
It impairs blood flow. Simple as that. Less blood means tissue damage and then organ dysfunction.
Kidneys and lungs, again, being prime examples.
Exactly. It's complex, though, a real interplay between genetics, the immune system's reaction, and maybe those environmental factors.
So when you suspect MPA, what else is on the list? The differential diagnosis.
Yeah, that's crucial. You got to differentiate it from the other ANCA-associated vasculitides first.
Like GPA and EGPA.
Precisely. Granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis. They share the ANCA link, but often look different clinically.
What else?
Other big systemic autoimmune diseases like lupus SLE or rheumatoid arthritis.
Yes.
Other types of systemic vasculitis, too. And really importantly, you have to rule out infections. Some infections can mimic these symptoms.
Got it. Makes sense to rule out the bugs first. What about numbers? Epidemiology. Is it common in the UK?
Specific UK data is a bit hard to pin down accurately, but fundamentally, it's rare.
Rarer than GPA, for instance.
Generally thought to be less common than some of the other ANCA types, yes.
And the age distribution.
Like we said, affects all ages, but definitely a higher prevalence in middle-aged and older individuals.
Okay, let's talk presentation. What signs and symptoms should ring alarm bells?
Often it starts quite non-specifically. Systemic stuff.
Like fever, feeling tired?
Exactly. Fever, fatigue, maybe weight loss, just general malaise, feeling unwell.
Then the organ-specific things kick in. Kidneys.
Yes. For renal involvement, look for raised creatinine on blood tests, blood in the urine, that's hematuria, a big red flag.
Proteinuria too?
Yep, protein in the urine, and hypertension, high blood pressure. We have a memory tip for this.
Let's hear it.
Think RQPH for renal, raised creatinine, proteinuria, hypertension, hematuria.
RPPH. Got it. Useful. What about the lungs?
For pulmonary involvement, you might see a cough, shortness of breath, maybe some chest pain.
Anything more specific?
Yes, hemoptysis. Coughing up blood. That's another really significant sign. You need to pay attention to that.
Definitely. Any other ways it can show up?
Sure. Skin rashes are possible, often something called palpable purpura.
Raised, bruise-like spots you can actually feel?
Exactly. Also, joint pain, muscle aches, and neurological symptoms can occur.
Like nerve damage?
Yeah, something called mononeuritis multiplex, that's nerve involvement, like weakness or numbness, popping up in different areas, different limbs.
Wow, so it can be quite varied.
Very. And many symptoms are nonspecific on their own, which makes the diagnosis tricky sometimes.
Right. So what investigations help piece it all together?
Okay, investigations. Blood tests are absolutely key.
Specifically looking for
The ANCA's evaluation, that's vital. We check for MPO-ANCA, myeloperoxidase, and CA.
also called p-ANCA.
Right, p-ANCA for its paranuclear staining pattern. That's positive in, maybe 50 to 75% of MPA cases.
Is there a memory tip for that one too?
There is. Think PAVE for paranuclear and P for polyangiitis, microscopic.
Nice. P for polyangiitis. What about the other ANCA?
We also check for PR3 ANCA, proteinase 3 ANCA. That's sometimes called c-ANCA for cytoplasmic pattern.
How often is that positive?
Maybe around 40% of cases. So MPO-ANCA is more common in MPA.
Okay. What else besides ANCAs?
Urinalysis and kidney function tests, obviously, to check for that hematuria and proteinuria, assess how the kidneys are doing.
Imaging, yep.
Chest x-ray or probably a CT scan to get a good look at the lungs.
And the gold standard.
The biopsy. Taking a small tissue sample from an affected organ, usually the kidney or sometimes the lung.
What does that show?
That lets us see the inflammation and damage in the small blood vessels right under the microscope. Confirms the diagnosis.
Okay, so once you have the diagnosis, how do you manage MPA?
Management hinges on immunosuppression. Basically, medications to calm down that overactive immune system and reduce the inflammation.
What are the main goals of treatment?
2 key things. Get the disease into remission, quiet it down, and then prevent it from flaring up again. Prevent relapse.
What drugs do you typically use?
Mainstays are high-dose corticosteroids, something like prednisolone, to get things under control quickly.
And then other immunosuppressants.
Yes, often alongside or after the steroids. Drugs like cyclophosphamide or rituximab are common choices.
Is it one size fits all?
Oh, definitely not. The approach has to be personalized. It depends on how severe the disease is, which organs are involved, the patient's overall health, other factors.
And I assume close monitoring is needed.
Absolutely crucial. Regular follow-up to see how treatment's working, manage side effects, adjust therapy as needed.
What about the long-term outlook? The prognosis?
It's quite variable, honestly. Really depends on factors like how much organ damage there was at diagnosis and how well the treatment works for that individual.
But with prompt treatment.
With early diagnosis and the right management, yeah, the outlook can be pretty good. Many people achieve remission, good long-term control.
But relapses can happen.
They certainly can. It often becomes a chronic condition requiring ongoing management and vigilance.
And if it's severe?
In more severe cases, especially with significant organ damage already present, the prognosis is less favorable.
Go. And what about potential complications down the line?
Complications really follow which organs were hit hardest.
So for the kidneys?
You can see chronic kidney disease, unfortunately progressing sometimes to renal failure needing dialysis, or even a kidney transplant.
And lungs?
Pulmonary fibrosis, scarring of the lungs, or respiratory failure are risks.
Many others.
Yeah, potentially heart issues, that nerve damage we mentioned, skin ulcers that won't heal, GI bleeding, and always a risk of infections.
Especially with the immunosuppressants.
Exactly. The treatment itself increases infection risk. So again, timely diagnosis and effective management are just key to cutting down these risks and improving outcomes.
Right. So let's do a quick recap for exam prep. Microscopic polyangiitis, rare ANCA-associated, small vessel vasculitis. Think kidneys and lungs. Remember RPPH for the kidneys, raised creatinine, proteinuria, hypertension, hematuria. And watch for lung symptoms like hemoptysis. Diagnosis often involves MPO-ANCA, the p-ANCA, and that crucial biopsy.
Spot on.
And treatment. Immunosuppressants like steroids, cyclophosphamide, or rituximab to get it into remission and keep it there.
That covers the core points really well. Recognizing how it can present, knowing about the ANCAs, the biopsy, that's vital for getting the diagnosis right quickly.
It might be rare, but you definitely need to know about MPA.
Absolutely. Crucial piece of medical knowledge.
And if you want more detailed notes, practice questions, really get this locked in for your MSRA, definitely head over to passthemsra.com. And there's also free MSRA.com for additional resources.
Great resources for prep.
It really makes you think, doesn't it?
Yeah.
The complexity of these autoimmune conditions, how the body can turn on itself, but also how much progress we're making in understanding and treating them.
Constant advancements. It's a fascinating field.
Thanks for joining us for this rapid-fire deep dive into MPA.